But yeah, welcome. This is the Center for Rural Policy webinar on healthcare. We just released some healthcare research, and we wanted to gather the actual true experts in the field to have a discussion about some of the trends and some of the concerns that are going on in healthcare across the state in Minnesota, and in particular in rural Minnesota. For any of you that have joined our webinars previously, you're probably used to seeing our CEO, Julie Tesh, do the kind of welcome to everybody, but anybody that lives in southern Minnesota knows that you've experienced some pretty significant storms. Yeah, last night, kind of in the evening hours, some tornadoes, some high winds, lightning, and Julie, her house got some pretty significant hail damage, down trees, and electricity has been on and off throughout the morning. We tried a practice session this morning and it was pretty spotty. So we decided as a group I would kind of take over and lead us through this discussion. On deck for today really is just a quick 15-minute presentation from us, just kind of an overview of our research real quick, and then we're going to turn it over to our panelists to kind of talk from their perspectives about what they're seeing, what they're hearing, and what they're feeling about these issues and topics. We have 4 panelists lined up. I see Santo Cruz is now logging in as well, so it'd be great to have Santo available. But let me just launch right into our presentation so we can go immediately over to the panelists. And so I'm just going to share our screen, my screen here. Okay. Real quickly, just about the Center for Rural Policy and Development. If you're not familiar, we were actually created back in the late 70s by the Minnesota State Legislature. We are a nonpartisan, nonprofit policy research organization, and we really focus on presenting, gathering information and research to state legislators that kind of work through some of the topics and issues that they're hearing from their constituents, or some policies that they're working on and what types of effects that might have on our rural areas. And so really our research really tries to shine a pretty good lens on rural Minnesota and try and figure out what's happening on the ground there. We're not a large organization. There's 3 staff members. Julie Tesh is our president, and it's important to know that we all work and live from rural Minnesota. So Julie Tesh is living and working out of her family dairy farm down in Waldorf, Minnesota. Marnie Werner is our director of research and vice president of operations. She lives and works out of Mankato. And I'm the research associate for the Center for Rural Policy. My name is Kelly Ash, and I live and work out of New London, Minnesota. We have 15 to 20 board of directors. It's important to know that 13 of them are appointed by the governor, 2 are appointed by House and Senate leadership. And then we have 5 at-large members to kind of fill out any sort of representation issues that we might have on the board through those appointed memberships. We are currently at 19 board members. Just real quick, if you want to find out more information about our research, our website is our go-to spot, ruralmn.org. There you'll find our research, our full kind of full-page reports, also short summaries. We also include other kind of news from local newspapers, rural Minnesota topics and issues that are aggregated on our website as well. You will also find that we just started doing YouTube videos, real quick 2 to 5 minute videos that gives overviews of our research. In case you're not interested in wading through our 20-page research papers, video can be a little bit easier to consume. And so go check out our website for our YouTube, or for our videos, and then we also are on YouTube as well. And lastly, we just started a podcast this year in January called The Center of Everywhere, and you can listen to those episodes also from our website. We have 4 episodes so far in the can. Once we get 5 episodes, which we are in development of, we'll be able to be on iTunes and other kinds of podcast subscription membership deals, so you can find us there as well, hopefully in the near future. The last thing I'll say is you can help us set our upcoming research agenda. Our research agenda year starts in July and goes until the end of June. We currently have a survey out that we sent out to every state legislature in Minnesota, as well as newspapers, editors, and publishers, as well as other kind of leaders across the state, to try and get some feedback on what topics we should focus on for this upcoming research year. So be on the lookout after this webinar. Probably sometime tomorrow you'll receive an email from us asking you to fill out that survey, and we'd really appreciate if you would do that as we can wrap that up and set our agenda for next year. We're excited to do that. Okay, for the question at hand, what we were kind of seeking out, or what we were asked to kind of look into, was what is the cause and impacts of healthcare service consolidations in rural Minnesota? And so that's what our research paper kind of focused on. In order to really have this conversation today, and I think even to get our panel up and running right from the start and not have to give too much background, is we really need to understand a pretty significant shift that's happened in the payment philosophy in healthcare in the United States as a whole. So prior to, I would say, the 1980s and 1990s, we had what we call here on the left the fee-for-service model. And that was healthcare providers were paid based on the number of services provided or the number of procedures ordered. So you get a patient, and you paid for the doctor's visit, you paid for the scan, you paid for the medicine. The whole process of treatment was paid individually. And so you were just kind of, payers were given an individual order of all the services they were given and then asked to pay. And the idea back in the 80s when research was coming out showing that the United States was paying some of the, probably the top 5 highest healthcare costs while having some of the lowest outcomes in healthcare in the industrialized world, it really kind of realized that we were incentivizing a higher cost heads in the beds model for our healthcare system. And so starting in the 80s, ramping up, I would say over the 2000s, we are shifting more towards what's considered to be called a value-based care. This means where providers are reimbursed based on the quality and efficiency of the care they provide, incentivizing essentially lower costs and better outcomes. That's theoretically what's supposed to happen. On the ground, this is kind of what it looks like as a theoretical difference in payments. Over here we have on the left the fee for service, so reimbursement for each patient for each service that they're given. But this shift is trying to do this type of model where a hospital or a healthcare provider is essentially given a lump sum of money and said, that's the money you get, treat your patients with that. We don't care how much it costs. If it goes over that, that's your loss. If it goes under that, you keep the profits. And this is kind of the model, the policies and the programs being developed today are kind of incentivizing this style of, I would call like business model for healthcare and for our healthcare providers. Some terminology you might hear, values-based philosophy examples, global payments to providers. That's kind of, you know, you give a healthcare provider a big lump sum and say, this is your budget for the year, make do. There's episode of care payments. So insurance companies or government programs could say, hey, we see that, you know, care for somebody that has a heart attack averages this much money, let's say $10,000. That's all you're getting for every episode of care payment for a heart attack is you're getting $10,000. We don't care if it costs you more than that or under that. That's just what you're getting. You have to figure it out. The other thing that this new value-based philosophy kind of incentivizes is more of a team-based holistic approach to care. Essentially what that means is that you might hear it called continuum of care. And so you may go to the doctor and they may treat you for a certain ailment, but then also you'll be treated maybe by a dietitian or any other specialist to kind of help make sure that they don't have to see you again because the original treatment didn't pan out as well. And you'll hear that quite a bit, and it plays a role into what's going on into rural healthcare. So there are strategies that are needed that healthcare providers are doing to adapt to this new philosophy or this shift. The first big one is risk sharing. You'll hear this a lot. So essentially it's like an insurance company. If you're getting a lump sum of payment for a whole bunch of patients, you're essentially sharing or spreading, I should say, risk across a big patient pool. So you're gonna have some patients that go, you know, don't cost as much, and you're gonna have a few patients that cost way more. And the idea is to spread that out enough so that the lump sum that you received is enough to cover all the care for the entire patient population. You also hear a lot about upgrading technology. So there's been a huge push for our hospitals and our healthcare providers to have electronic health records. You're also going to hear more about telehealth. You're going to hear more just about some of the technology that's being released for better services, for better care. All this stuff requires a significant amount of money. If you talk to any sort of healthcare provider, administrator, they'll see, you know, besides staff, technology is their next biggest expenditure, particularly capital expenditure. Another strategy that's needed is development of enhanced coordinated care. And so, you know, a lot of our healthcare providers, they will have maybe a lot of specialists or a lot of different care services, but it hasn't always been the case where they have all worked together or have been expected to communicate together on a single patient or a group of patients at a level that's being expected now. And so this has really changed a lot of workflow issues within healthcare provider systems and how they operate. There's also the utilizing of efficiencies. So as you can imagine, if you're treating a large amount of patients, the amount of supplies that you want to purchase, if you can purchase those at a larger bulk, you can get larger discounts for those supplies, utilizing those types of efficiencies. And there's also this last piece, negotiating higher reimbursements. This could be from insurance companies or whoever, but really trying to plug where they may be losing money with some higher reimbursements from other services or from other payers that they might be in negotiations with. So those are some of the strategies that they use to adapt. So what does this look like for rural hospitals and rural healthcare in general? Going into this, one of the things that I think a lot of folks expect on the ground is that these larger hospital systems are just coming in and gobbling up these smaller physician groups and smaller hospitals and healthcare providers without any sort of care for those smaller places. But actually, it's kind of the opposite. As one doctor in central Minnesota explained, when we were looking at our future projections, we knew we couldn't make it on our own as a smallish physicians group. We knew we needed to merge with a larger system to help our financial outlook. Why is that? There's a couple reasons. The shift in payment philosophy kind of puts small patient pools at a disadvantage. And small patient pools are kind of the name of the game when it comes to rural healthcare providers. With small patient pools, they aren't able to do risk sharing as effectively. They may not be able to have the capital to upgrade their technology. It's harder to utilize efficiencies. If you just have a smaller patient pool, you're purchasing smaller, you're not buying as much stuff or supplies in bulk. And you don't have the leverage to negotiate those higher reimbursement costs. And so you're really just left at a significant disadvantage. Also, a lot of research has been done around rural healthcare providers being able to attract specialists. The Minnesota Department of Health and the rural healthcare provider, or the rural health primary care office, does a lot of research on looking at some of the struggles that our hospitals and healthcare providers get in finding specialists. And if you're not able to offer a specialist, it can be more challenging to develop that enhanced coordinated care, which the shift in payment philosophy is really incentivizing. There's a lot of grants and programs available for medical providers that are able to do or develop really enhanced coordinated care. And it can be a little bit more challenging when they don't have these specialists in-house. Then there's just a flat out reality that rural healthcare just costs more to deliver. We're older, we're sicker, and we're poorer. Look at any research, and that's pretty much one of the main things or main themes that come out about rural healthcare is this is kind of the reality. What this means is, looking at this chart here, these are the margins for each hospital in 2018. So each point on this chart are entirely rural hospitals all the way up to our entirely urban hospitals. And you can see the average margin, which is the amount of profit they made as a percentage of their total revenue. And you can see the average margin for our entirely rural hospitals is 0.1%. And about 70% of our hospitals actually have unhealthy margins, which means 4% or less. As you work your way up, you'll see the margins increase significantly, 1.8%, 3.1% to 6.2% for our entirely urban counties. So not only are rural healthcare trying to negotiate this shift in payment philosophy that's trying to incentivize cost-cutting measures and trying to find more efficiencies, they're doing this in a reality where they're already pretty slim on margins, and cutting costs is pretty asking a lot for some of these healthcare providers. So large is the name of the game. Large patient pool plus a smaller patient pool means it opens up all these possibilities, which is a big reason why we've had some of the larger system administrators tell us, like, look, we get contacted by smaller healthcare providers wanting to be acquired or wanting to merge with us to make this work and make their financial situation a little bit better. And now, of course, we're dealing with the impacts of COVID-19. As many of you know, a lot of the revenue that's generated from some of the procedures were actually canceled or not allowed to happen during the first kind of beginning of COVID-19 crisis in the pandemic, as healthcare ramped up to try and prepare themselves for any sort of surge in patients that they might have. And so a lot of that revenue was completely lost. Now that elimination of those services has been lifted, and now some of those hospitals can perform again some of these procedures. But if you still talk to our healthcare providers, they'll still tell you that their revenue is way down because patients are just scared to come into hospitals or to their clinic or to visit their physician. And so people are just canceling their appointments or not seeking help as much as they should right now anyway. And so it's still a big problem. So that leads us to this kind of big issue where, even if you're a larger healthcare system or an independent or smaller healthcare provider system, you're probably going to have to be cutting costs. If you weren't already, COVID-19 is pretty much going to make sure that you have to, unless we come up with some pretty significant package to help our healthcare providers make up some lost revenue. And really the big options for cost cutting, and you're already seeing it with layoffs and furloughs, is one, you got eliminating services. So for independent, smaller rural hospitals, you'll see that they'll just eliminate the service in general. If it isn't due to cost-cutting measures, it also might be due to the fact that they can't find a specialist to fill the need for that particular service. If a smaller provider is a part of a larger provider system, then they can relocate those services. And you'll see that quite a bit now, where some of the larger systems will look at their financial situation and say, hey, you know, some of these smaller healthcare providers lose money in some of these services, and we offer it, and it's duplicated amongst a lot of our facilities across the state that we might have within our system. So let's cut it there and relocate it. And so we send those patients to one of our larger hospital facilities, so we can make the book's budget or balance a little bit better. And then this last piece is elimination of staff. And this one is concerning, particularly for our rural areas, because these are some of the higher paid jobs in our regions, and they're good jobs. And so as we're talking about elimination of services and relocating them, it's not only about access to healthcare, but it's also about jobs and incomes being lost as well. So what does access actually look like today? This was a tough one to get through. And so let me just talk a little bit. This is borrowing some slides from the Minnesota Department of Health, their health economics program. They do kind of a rural health access survey where they send it out and kind of try to do some analysis of like, what are we seeing for services? And this is kind of a large table, but just to provide some examples, you know, just looking at inpatient surgery and outpatient surgery, since 2009, you can see there's been right around a 10% loss in the number of locations that were offering those services in rural Minnesota. Mental health, we've seen an increase in psychiatric, but detoxification has dropped by 30%. We've seen some drops in scanning and some drops in the renal dialysis services. This is just an example of kind of what we're keeping track of, and to show that some of the anecdotal evidence that we've seen or have heard from folks on the ground living in rural Minnesota that yes, you know, the feel that you have of losing some of your services is real and it is happening. Here's another slide. A lot of folks talk about obstetric or birth services across the United States or across Minnesota. This is 2003 to 2018. The darker shaded counties are the counties where birthing services are not available. And you can see in 2003, there were already a few. And by 2018, we've already added quite a few more to the map here that no longer have the birth services. And, you know, a particular concern I would think is in Northeast Minnesota, where you have Lake and Cook County up there. You know, those are landlocked counties. There's only one spot they can go. It's Lake Superior on one side and Canada on the other. So they really can only go to Duluth. So that gets to be a significantly large distance for birthing services up in northeast parts of the state. And that's really significant. We just analyzed some discharge data just to kind of provide us with some kind of like, okay, what does it actually look like? And this is the average miles traveled for 3 specific inpatient services that we looked at: cardiology, neurology, and obstetrics. And you can see patients that are from our entirely rural or our town rural mix. These are patients from those counties. Let's take cardiology, for example, here. They've had to travel on average about 75 miles for that service, compared to less than, you know, right around 20 miles for our entirely urban patients. And so you could see across the board that there's just significantly longer distances that the more rural you are, the more likely you have to travel for certain services. Kind of wrapping this up is this also piece about rural frustration. So we went out and kind of talked to some leaders across the state, interviewed some folks that have experienced service loss in their area, either through consolidation or just elimination of services. And there's a real frustration among rural residents about how this is kind of happening across the state. One example we have here, and we actually have Brad Erin's on our panel to kind of talk about this from Albert Lee, is the one unique aspect of the story was how Albert Lee kind of rose up and organized around this issue. For some of you that don't know about this, Mayo announced a couple years ago now that they were going to take out a significant number of their inpatient services away from the Albert Lee Hospital and consolidate them to the Austin Hospital, including birthing, obstetrics, and birthing services. And so Albert Lee kind of raised a little bit of a ruckus in their community about this. Now, I'll have Brad talk about it a little more, but that story and some of the other stories that we heard from some of our other interviewees taught us a few things. One is a desire for local input. So a lot of these services are being consolidated or taken away without any sort of process in place where local folks can come in and say, hey, this is a problem. There's also a need for assessments. This was particularly learned in Albert Lee, where the Mayo pulled back on some of their inpatient services that they were offering due to financial concerns and staffing concerns. And they actually did some of their own assessments on what is the financial feasibility to have a level 2 trauma center in their community to serve that region. And the assessments came back, relatively positive that, hey, this is a possibility. And so I think, a desire for local input and a need for assessments, and then that there may be room for competition was some of the main themes that we were hearing from some of our local folks on the ground when they are going through some of these challenges. So that leads us to our last slide here. This was the recommendations that came up through our report. And again, you could check out our full report on our website, ruralmn.org, to kind of get a lot more detail about than what I'm going through here. But the first recommendation we had was that there should be a review process for consolidations of services. For most of you, you probably don't realize that if a clinic or a hospital wants to open up more beds or move into an area and have hospital beds in that region, they actually have to go through a process with the Minnesota Department of Health that makes it so that requires them to essentially prove that they're needed, that it's needed. So even in Albert Lee, where Mercy One has announced that they're going to move in and open up a clinic and down the road a full-fledged level 2 trauma hospital, that's the plan. They'll have to go through a process to prove that that's needed and that can work. What's interesting is that there's a process to do that, but there's not a process when a healthcare provider announces that it's consolidating services. And we heard this a lot from folks on the ground, from leaders, county commissioners, city council members, and economic development folks, was that how come a healthcare provider can just announce and do this without any sort of process that they have to talk to us, or that we can do an assessment on what the impacts are to access after they do this. But yet, if we recruit somebody in to add some competition or to open something up, there is a process. That seemed backwards to us. And so that was something we kind of recommended that the legislature could take a look at. The rest of these, so treat rural healthcare providers differently. This was just looking at policy and not putting any sort of, not implementing any policy where it's just kind of this one size fits all sorts of policy, because in healthcare, these things operate very differently. And we would even argue and go a step further and say that even within the systems themselves, to not treat a system as one healthcare provider system as one large hospital provider, but rather a network of small providers and larger providers, and get treated differently within that system. The third part is assess negative impacts any cost-saving policy proposals would have on rural providers. Legislators are increasingly looking at how to cap costs or cap the growth in costs within hospitals and healthcare providers. So we've done a lot of work on the insurance side of things, and now there's this increasing pressure to look at the actual healthcare cost side of things. And so there's been a lot of proposals tossed around about how do we, cap costs. There's been some states in the United States that have flat out told healthcare providers that this is as much as you can charge for specific services. You won't get reimbursed any more than that. And those are okay things to look at, but we just need to understand that sort of proposal will have different impacts dependent on our healthcare provider and the size of their patient pool and where they're located. Examine what revenue streams hospitals rely on and explore alternatives. So with this big shift in payment philosophy is that the healthcare providers have essentially been incentivized to take away inpatient healthcare beds, like heads in the beds model. There's grants and funding programs available for healthcare providers to essentially eliminate more of their beds. And there's nothing wrong with that. Research says that that's appropriate for getting better outcomes and lowering our costs. But it does take away a significant revenue stream for many of our rural hospitals. And so we need to find out and examine what revenue streams hospitals rely on. And hopefully some of our panelists can maybe talk about that a little bit today. And then the last thing I'll say is explore policy that gives communities more input in the decisions made about their healthcare. Every healthcare provider and every healthcare system, it operates a little bit differently. Some of them, when they come into a community and say, hey, you know, we're going to merge or acquire this smaller healthcare provider in your community, we would like somebody from the leadership of that community to sit on our board, so there's some input onto some of the decisions being made. In other healthcare systems, that's not the case at all. There is no local input. There is no one local on the board to help inform these decisions. And so there is room, we think, to explore some policy where, you know, that a healthcare provider, if they're providing services in different areas, that there has to be local representation in the decision-making process for that service area. So with that, I'm going to launch right into our panelist Q&A. We have a lot of questions. We received some from some of our panelists or some of our participants that are on the webinar currently. We also received some through email previously. But we're going to start out with just a few to kind of get the rails running. And I'm actually going to start with Terry Hill. And I'm going to actually I'll ask you to introduce yourself here in just a second too. Terry Hill, he's another researcher, does a lot of work around healthcare nationwide. And, you know, our research just kind of looked at Minnesota. Terry, could you put into context the trends and mergers among healthcare providers and service consolidations in Minnesota compared to national trends? You know, do you see Minnesota following these trends, or are we forging our own path?
Well, thank you, Kelly. And we work in all of the states that have rural areas, and I personally worked in every state as well. I think what we're seeing here is pretty much what is happening across the United States. Minnesota is in a lot better condition than, let's say, the states in the South where Medicaid expansion did not take place, and we're seeing significant closure of rural hospitals pretty much in general. Affiliation, we've seen a pretty steady increase in the number of rural hospitals that are looking to affiliate with other hospitals and other big healthcare systems. Part of the advice that we give to hospitals, if they're looking in this direction, is pretty much decide really what you want. Decide what's going to be important for you. Do community assessments as well. And this next one I think is particularly important. Assess the value that you bring to this arrangement and to the system. We are like midway through an entirely different payment system. And in that payment system, rural hospitals and rural communities have new value, because it isn't going to be about sending all the patients into the big centers anymore. It's going to be actually working so that we can keep our local citizens at home. Obviously, if you need heart surgery, you're going to go to one of the big healthcare systems. But we've got to make sure that our rural hospitals are documenting their value and are able to then put themselves into a win-win situation with these big healthcare systems. When we go in hat in hand as poor us, it doesn't work very well.
Okay, thanks, Terry. I'm going to circle back with you on looking at some policies that other states are implementing. I think there might be some curious things there. But I kind of wanted to open up to Santo Cruz. Santo, my question for you, as a larger system, you're part of CentraCare. Can you provide context into the financial pressure your system feels, not only in the shift in the payment model, but also changes to our population demographically, and also within the context of COVID-19? You know, within your system and what you're hearing on the ground, how at risk are the smaller providers in seeing future service consolidations or even closures? And Santo, if you could also introduce yourself as well, I would really appreciate it.
Sure, no problem. I live in rural Minnesota, so I apologize that you can't see me. I have a bandwidth issue, so I hope you can hear me okay. Can you hear me okay?
Can hear you great.
Okay, so Santo Cruz, Vice President of Government Relations and in-house counsel at CentraCare Health. We serve about 600,000 or provide access to over almost 700,000 rural Minnesotans. We work exclusively outside of the metro and greater Minnesota. With regard to the pressures, obviously we've done a lot of acquiring new relationships, joint ventures. I wouldn't say that we've looked exclusively at purchasing or taking over hospitals more recently. Some of that is driven by the financials, and some of that is driven by some of the things you're talking about today, where local communities kind of want to know what it is that they're going to have a seat at the table for in the future. And so maybe at the end of this response or down the road, I'll talk a little bit about our newest relationship with Meeker Memorial out of Litchfield, which they own, they run, their CEO and board are still in the place, but we actually lease all of our staff. So all of their workforce is actually CentraCare employees. Okay. And so we provide those specialties, and that's a very unique arrangement. With regard to the financial pressures, I'd say I've heard other CEOs of healthcare systems explain it this way, and it is really hard to argue with. We have three types of patients when it comes to the financials. Obviously, everybody's unique circumstances with regard to their healthcare is very personal. It's very private, and it's incredibly important for our loved ones. But the economics of it are rather simple. We have those folks who engage with healthcare and use more than their insurance pays for. We have those people who pay nothing. And then we have those people, this is the commercial insurance market, who cover their own care and then the delta between the other two. And that's the dirty secret we don't really talk about in healthcare openly very well, is that as we see the demographic shift, both for Medicaid, so in Minnesota, about roughly 45 to 50% of all the children born in Minnesota are born on the Medicaid program, meaning that's a federal and state subsidized healthcare product in terms of for reimbursement insurance. And then, of course, we have exploding demographics with the age wave of people aging into Medicare, which again is a government reimbursement model. This will sound very familiar to our farmers on the line. When it comes to government programs, hospitals are price takers. We're not price setters. There's no negotiating with Medicare or Medicaid when it comes to the reimbursement for those patients. And typically, those programs do not cover their total cost of care, their usage. That's why, as Kelly talked about, we really do try and focus on the value-based models and coordination of care to try and make both the outcomes work better and the economics work better of serving those two populations. What that means then, if there's a wave of folks moving into Medicaid and a wave of folks moving into Medicare from a demographic shift, that more and more is being asked of the commercial insurance company. And that's actually becoming a narrower and narrower slice of the pie. So that's where the real frustration comes from the general population that says, why am I using my healthcare from my employer about the same as I always have, yet my premiums go up and up and up and up? It's not because your insurance company is stupid. They're very intelligent. And it's not because they're not good negotiators. They're incredibly good negotiators. It's because they realize the fundamental unsustainability model of having the largest part of your pie not fully compensating for its usage. And so that's where we get into a lot of these pressures that you talked about at the top of the hour around how healthcare is delivered on small scale is so challenging for small towns and so challenging for small populations. You don't have the tools to manage the population as well. It's not that big of a population anyway. And as you said, they're usually older, they're usually sicker, and they're usually poorer. So when we come into those relationships, we really try and look for where do we add value, where do they add value, and how can we serve that community better and keep that kind of common geography intact.
Okay, thanks, Santo. I guess, Richard Ashe, I know you're the CEO of United Health down in Faribault, and you're kind of what we call a smaller healthcare system, I guess, or provider. From your experience, how are you feeling about this financial pressure? You guys are a little bit more unique in this, that you're not a part of a larger system. What pressures do you feel?
Well, I guess first, my name is Richard Ashe. I'm the CEO here at United Hospital District. in Blue Earth, Minnesota. And I've, like many of you, I think, attending this webinar, have been in the business for many, many years and have seen a lot of change over the years. We're a small critical access hospital. We've got 3 satellite clinics, 1 attached clinic. We basically are a small rural mini healthcare system, short of the long-term care part of it, with ambulance and home health and hospice and those types of services. I don't know, a lot of this may sound duplicative of what Santo had said, because really, I think he nailed it. A small rural facility like ours, from a payer perspective, we get excited if they call us and talk to us, as opposed to getting a letter stating this is what your reimbursement's going to be for the next year for your contract. So we really are limited. And I know Terry had mentioned something about coming to the table with your hat in the hand. Sometimes it's hard to have a different perspective when you have the smaller negotiating resources available. So it is a challenge. And I do think we're at a turning point in rural healthcare where I guess I get a little worried about what our rural communities are going to look like, because one of the other pieces to this pie, from not just the finance from healthcare, but for the rural communities, is many times we're the largest employer in the community or in a large area, or at least in the top 3 anyway, unless there's a school or something of that nature. And so taking out a hospital or reducing services or losing services has a pretty significant financial impact on the community as well. So there's a lot of pressure from a lot of different ways. It was talked about economies of scale. And when we talk about the fee-for-service or pay-per-click going to outcomes-based, those intentions are good, and we all want to improve the care we provide to the people that we see at church or at the post office or at the grocery store. We don't want any bad outcomes. But when you're trying to do a population health perspective all by yourself and your communities, that's very hard. 1, from just the number of patients in your population, 2, from the resources that you have available. So it's very challenging. The pressures from negotiating with the insurance companies, the financial pressures from wage competition, as healthcare workers become more and more scarce, and the competition for them it grows, that cost per dollar increases. And so we have to compete with the larger facilities around us. And in our case, Mayo is the largest provider for many miles. And so that's another financial pressure that we've been seeing, and we expect to continue to see those types of things. So, I guess I'm not sure if there's how deep or how far we want to go into this, but I think the financial pressures are huge. And actually with COVID, I think it's going to even be more traumatic, because we don't know what that's going to look like. Even though we're starting to restart or reopen our surgeries and our visits, the social distancing, the procedures and processes that have to be put in place to where there is more separation and security and safety for staff and for patients. There's no way that you can get back to that 100% volume that we were at previously. And that would put us at a 1, maybe 2% bottom line net income. And so just by the mere fact of having lower volumes that you're not going to be able to get to, we know most hospitals are going to be losing. So it's a challenge out there. I'll stop at that and let the group continue and weigh in, I guess, where appropriate.
Yeah, sounds good, Rick. We'll be circling back to talk a little bit more in depth on a few of these things. I did want to get to Brad Aaron's real quick to talk just from a more local communities perspective on how Albert Lee kind of went down with this, how the community felt. And Brad, in the presentation, I really just quickly waxed over what you guys were doing in Albert Lee and some of the efforts that you did. If you could just introduce yourself, maybe provide just a couple-minute overview of some of the work you guys did, the situation you're in, what has happened since then. And then I would just love to hear just some of the some of the tips that you've had to anybody that's local that maybe would think about organizing or doing something similar to you guys that you would have for others that might be in the same situation that you were in a couple years ago. So hand it over to you.
Well, thank you for including us. This has been a fascinating journey that the community of Albert Lea and our citizens have been on. I was drafted. I was drafted to lead an organization to help save our hospital. The name of the organization, it was a community action group called Save Our Hospital. I'm a local business owner who has some background in not healthcare, but health insurance from a consulting standpoint. And today I am president of the Albert Lea Healthcare Coalition, which is a formal 501c3 approved, IRS approved public charity that is an offshoot. It is what the organization of Save Our Hospital morphed into as we progress down this road. How did we feel when this bomb was dropped on us? It felt like a bomb was dropped on us. I mean, we had no advance warning. We were a proud Mayo town. We bragged about it. And so how did we feel? We felt abandoned. We felt violated. There was anger. It was devastating, quite frankly. What did we do? They announced this in a large public venue. They basically announced it at our local high school, the biggest auditorium that they had, and there was let's just say there was a hearty crowd of citizens there. None of us had any advance notice. And as I said, there was anger. And immediately there were a number of groups, citizens groups that kind of rose up and said, we've got to fight this. And we couldn't do it as one group. We couldn't. We had to unite. And I was asked basically to do that. And it wasn't easy at first because every group wanted to, had their own person that they wanted and things like that. But we quickly came together. And what was the key? We had to unite. Secondly, we had to get the city and the county on board. As a citizens action group, we had literally no power except our voice, which can be very powerful, but we had to get the city and the county on board because they had actual power. And together, it didn't take long. We united as a city, county, and citizens action group. And for the most part, over the course of this, several year ordeal, we have stood as one. And so what's the key? You've got to get the city and the county and the citizens all on the same page. Secondly, you've got to organize it and you've got to treat it like a business. Even though it's not a business, you need to have, it can't just be a couple of people. You need to put together a steering committee is what we called it. And that group needs to be between 10 and 20 people. Why? Because you're going to have a number of subcommittees that you have to put together, ranging from, a political action committee to a citizens and community service committee to a marketing and PR committee. You have to have enough people engaged that are willing to work on this. And it's work. It is. I've had 2 full-time jobs for several years now. And one pays me and the other one gratifies me. I get a lot of gratification from it because it has been something that has been very rewarding. And I've been on a lot of volunteer things, but nothing as rewarding as this. So organization is key. You can't give up. They're banking. Mayo banked on us giving up because we weren't the first ones that they did this to. They did it to Fairmont, for example. And we used Fairmont. The people from Fairmont came over and gave us some tips. And at the end of the day, Mayo just outlasted them and they gave up. We didn't give up. And, one of our subcommittees was an alternative to mail. We started this out saying our goal is to get them to change their mind. It became, within 2 months, we knew they weren't going to change their mind. There was no budgeting. There was no negotiating. We had what was called facilitated dialogue, which was basically, the state of Minnesota requested that Mayo at least sit down and talk to us, but all they talked to us about was, here's our plan for how we're going to implement this over the next few years. Our changes, the removal of services. You cannot give up because they're banking on it. You're going to have to raise money. And that's not easy to do, but it will be easier than you think. We raised almost $200,000 as a citizens action group. Why did we need that money? Because you're going to need to hire outside experts to come in. Mayo did this without any health impact analysis on what was going to be the impact of their decisions on the city of Albert Lea and the surrounding community. The city of Albert Lea is about 18,000 people, but our hospital serviced between 50 and 60,000 people from not just the rest of the county, but counties around ours, including 2 counties just south of us in Iowa. We're a border community and county, and those communities already don't have a hospital. And the businesses down there like Winnebago and the casino, they were sending their people up to Albert Lea. We were the closest hospital. You're going to need money, and you're going to need to hire outside experts to prove that a full service acute care hospital can actually be a viable business in your community. And we spent almost $100,000 on hiring an outside expert. And they came back and they said, yes, if you can get patient count hitting these numbers, you can be viable in a community like Albert Lea, but you've got to get the patient count. You're going to have outside experts for that. So you need money. Eventually, you're going to have to become an entity that has power. As a citizens action group, we had no power except our voice. We had to morph into a 501c3 public charity that could raise money and speak with not only its voice, but with our money. And that's what we did. You're going to have healthcare lawyers that know how to do that, and they're expensive. Those people are good. They've been down this path before without other communities, but they're $500 an hour people, and they're worth it. They are. I don't regret anything that we've done there, but you've got to have money to do that. You have got to get the businesses involved in this. If your businesses don't support this, it will not work. Our businesses were enraged because it immediately made us harder to compete as businesses for people to come into a town like Albert Lea, to move here. It became, economic development, the fact that no economic development impact statement was done by Mayo ahead of this was, it was not only apparent, but it was so unfortunate because it did impact the city of Albert Lea and how we compete, with communities like Austin, which is only less than 20 miles away, and Owatonna, which is about 35 miles away, and even Mankato, which is about 60 miles away. It was just critical that we raised money and didn't give up.
Thanks, Brad. Appreciate that. We're going to circle back around to you, and actually we're going to do another round of this. We're getting some questions through the Q&A here online, and I think we have some legislators that are in attendance today as participants, and some other kind of local leaders, and really want to have a little bit of a discussion on what do you guys see as like some solid, valid solutions to some of the issues you feel like our smaller rural healthcare providers are facing. What, particularly Santo and Rick, maybe, I'm gonna start with Terry, but Santo and Rick, maybe ponder on that a little bit. What would you tell the legislators would be really helpful for you guys to really either one, stop the consolidations that might occur in the future of services being taken away from some of our smaller rural areas, or what are some of the ways in which we can incentivize alternatives to access like telehealth and things like that. So you guys ponder on that. Brad, ponder on, at a local level, what do you feel like would be super helpful from state legislation or a state agency. But I want to start with Terry. I know you guys have done a lot of work looking nationwide at some of the state policies that are being implemented. We had some recommendations in our paper that were more kind of like, hey, just keep an eye on these things as we're talking about this stuff. But Terry, what concrete legislation have you seen passed nationwide that you feel like has either been successful or at least is being tested that might help, slow or at least stop the reduction in access in rural areas across the United States?
Yeah, and that's a difficult question. To my knowledge, there is no state legislation out there that is slowing down consolidation. This may not be a popular opinion, but we're in the process of a massive trend towards consolidation, and it's not just impacting our rural communities, although that's the ones I'm personally concerned about. It's really hitting the bigger centers as well. So we've seen this, it's been going on for quite some time. And I think the really important question is, how can our rural communities come together and support the healthcare presence that may be in place? And I think another thing very important here is to really understand the kind of not only where the industry is going, but how can we forge this value so that we can keep the services that we have. But one of the things we talked about is access to specialty care. The one point I really want to make here is, in the last 2 or 3 months, we have seen an extraordinary explosion of telehealth. The 11 largest healthcare systems in Minnesota, for example, went, according to Stratus Health, which is our quality improvement organization, went from 1,400 procedures a day to well over 15,000. I calculated that's 1,350% increase. Telehealth is going to be the future here. I was on a call yesterday with one of the medical leaders of United Healthcare, and it's pretty much across the board, whether it's Blue Cross Blue Shield or wherever you're looking here. They all, basically what I heard is, we're not coming back from this. We think Medicare is going to improve telehealth. That means our rural communities can have access to specialists. We also see, when we take a look at, let's see, that one of the big obstacles was physician resistance. But we know United Healthcare reporting for all the physicians that they've been working with in the last 3 months, we went from a 22% experience rating. In other words, 22% of the physicians had used telehealth, and now it's over 75%. That's just a massive jump. The resistance of physicians is largely being overcome here. And then another big obstacle was, will our rural people, or rural people in general, not want to use telehealth, or will they see it as inferior? But again, United Healthcare reports that on average, all of these, remember that we're talking about 260,000 telehealth visits, they're averaging somewhere in the neighborhood of 4.8 and 4.9 out of 5. Another study I saw indicated that over 90% of the patients wanted to do this as well. So the one big point I want to come out of this is, if the legislators want to do something, we have got to get telehealth into our communities, and we've got to increase the broadband. And I know that's largely a federal issue, and I'm involved at the federal level with broadband expansion. And then the second thing is, I think what we're getting coming out of COVID-19 is, we have an economic interdependence here. So it's not just the hospitals. We can't talk about just the hospitals and clinics separately. We've got to be working with that economic development sector. We've got to be working with public health. We've got to be working on more of a community-wide level. And I see states starting to do this. The state of California, for example, was on track to put all of its Medicaid into these value-based models. The state of Oregon has already done that with its Medicaid program. So I think one of the biggest challenges from a statewide basis is to be able to work out adequate payments for Medicaid for our rural hospitals and clinics, open up the codes and payment for telehealth. And my concern is if we do not, it is absolutely easy from an urban center to be going down to Rick's Hospital or wherever. And so we're going to see a lot more competition coming for our rural patients in that regard. So let's do what we can to take the regulation, anything that's standing in our way that is stopping rural telehealth, including broadband, we've simply got to overcome.
Santo, you want to comment a little bit on what Terry just said, talking about first, the telehealth perspective? How do you feel like, from your system, is that a possibility, and what are some of the particular state barriers you see in implementing that? And then also talking about what do you feel like are some of the local solutions? Some of the local citizens got together and made this, how can they better support healthcare providers in their region? So why don't you start with telehealth and then we'll move on.
Thanks. Absolutely. Well, Terry hit it out of the park. He's absolutely right. We were doing telehealth prior to COVID-19. And then we started seeing executive orders from the governor and from the president rolling back a lot of the barriers regulatorily to providing telehealth services in a more convenient way. And CentraCare, along with Mayo and many other systems in Minnesota, are part of a coalition with Land O'Lakes and really being headed up by Land O'Lakes to increase the infrastructure in rural broadband and to codify in law a lot of the things that are being temporarily rolled back right now, because as we've seen, this is what the patient really wants. I put it akin to this in terms of, when I was in high school and college, I got paid with a paper check and I went to the bank to deposit it, and you had to physically go to do that. There wasn't another way to do it. And then slowly but surely, we all trained ourselves to do it electronically or through the ATM or even an app on our phone of taking a picture. And then checks kind of disappeared from our employment situations. We've gone through that arc of really training and accommodating what the population wants in the past 3 to 4 months, almost like a crash course. We are seeing some of our patients that are in their 80s and 90s getting their healthcare through their iPads and doing it rather successfully. So I think there's a presumption that, this is really a great idea for a certain demographic, but it probably doesn't serve older or more rural. We're not finding that. So we are very excited about the opportunity to build that infrastructure and to build those relationships with people in their home in a way that makes more sense. And it's certainly a much more cost-effective and efficient way of delivering care. I think you always have to know, though, okay, when something really emergent happens, is there still that healthcare infrastructure locally to do the emergent procedure, whether that be a heart procedure or getting radiation oncology or you name it.
Or birthing,
so I do
you hear that a lot.
Exactly. Yeah, exactly. So you do need to have this, it's got to be an and, not an or, but it's a huge, huge asset in the preservation of local infrastructure and providing people access in rural Minnesota for sure. In terms of, I'm sorry, go ahead.
Well, yeah, and Santo, I guess just on that point, telehealth is great, and that's kind of a solution for, a nice chunk of services, but still, when you talk to communities on the ground, a lot of them are like, oh, we lost our birthing services. We're trying to recruit young families to our area to fill jobs that we have available. They feel like that's a significant thing. Has CentraCare or folks you've talked about, are there local solutions to trying to keep those types of centers available in some of our rural areas yet, or is that just out of the question?
No, absolutely. I'm glad you asked this question because it gets to a few of the comments on the chat. And one of the chat said, if it kind of had a presumption said because consolidations raise prices, then wouldn't there be some incentive for health plans to keep folks independent? And I want to make sure, and I don't think that the report that's been published draws this as a necessary conclusion, because it's certainly not the conclusion that has been the case in at least my own experience. While a consolidation can lead to higher prices, it is not necessary that it do so. I'm not aware of any time where we have gone into a community and then just raise their charge master prices. Those are posted on the federal website. I could end up being wrong in a onesie twosies kind of way, but in general, that is not the process in terms of coming in and just using the local town to get a higher reimbursement rate. And so I want to make sure that we're clear on the fact that there are absolutely trade-offs when it comes to consolidation. There's no doubt about it. And those trade-offs often come with real human impact. But just along with the assumption about pricing, there's absolutely a false assumption that a consolidation leads to a reduction in services. More often than not, we're adding services, not taking them away. When we come into a critical access hospital or community-based hospital, and that's usually done through a dialogue while we're getting into that joint venture or relationship or management agreement. So if you have that, that local dialogue, you can have a discussion with the folks locally and say, your volume just doesn't, it's never going to get to a level that's going to justify an OB, and you can be really plain with folks about that. And that doesn't change the impact of the loss of that service, but it does help them understand, here's the transparency on the economics. They just don't pan out in this favor. Now, I will say, OB is one of those things that even when the economics don't pan out, we tend to do it anyway, just because there is that pull locally. So, but we have to have that dialogue to know, okay, you're asking us to move in an inefficient direction. So what else do we need to do to compensate for that? And it becomes really a dialogue of saying, okay, it's really important to this community that they continue to have OB services. For example, my 5th daughter was just born in a critical access hospital. She was born by a midwife, and that was my wife's choice. She could have had OB. There was OB backup, but she was delivered by a midwife, and so that was my wife's choice. And there was the OB backup through Centricare, but nevertheless, that volume is very, very low in rural Minnesota because we have less and less births. So it's a dialogue. I completely agree with every panelist in terms of the trade-offs and the tensions they've been talking about. And to that, I can really only say this. We can't have a singular focus in healthcare. We can't have it be singularly efficiency, singularly competition, singularly access, because all of these things are competing in a way that create natural trade-offs that we have to account for. And so we have to be really honest. And, you asked about kind of what are the policies locally that I would recommend or for people who are, getting in communities. For communities, I'd say get into that dialogue early, because what was described to me on this panel, and I've been on panels with, Saver Hospital and around with the folks in Albert Lea. I even went down there the year after it happened and was on a panel with a number of folks addressing that situation just from a healthcare system's perspective. That sounds like a lot of work on the back end. And it sounds like a lot of money on the back end. And I'm very, very impressed that community was able to put forth that effort. But I grew up in the town of Melrose, has 3,000 people in a critical access hospital. And that sounds like a really daunting thing to be able to pull off. I can't see my hometown of Melrose getting a $500 an hour lawyer to get involved in that situation. So I think that, as with healthcare, prevention and early intervention is usually less expensive and easier to pull off. And so I highly recommend folks get in that dialogue early and often before that transition gets made, so that everybody knows kind of what they're getting into.
Okay. Rick, I'm going to turn to you. From your guys' perspective, going back to this question about telehealth and then some local solutions from a smaller, healthcare system, provider system. How do you feel about that? Do you guys see barriers that might be different from what Santo is talking about?
I think overall, I think we all are somewhat on the same tune. I think the challenges may be a little different, community by community, but overall, they're also, I think they're more similar than they're different.
Okay.
That being said, though, I think the telehealth, I agree, it is an opportunity for rural providers to, I think, actually be able to provide more care and better care to their communities. But I think it needs to be supported not only by other providers rather than from a competitive perspective, but I think from the insurance side of it as well. Small rural independent facilities like ours, we've got awesome people. I'm amazed every day at the things that they do and the challenges they overcome. But we don't have a master's prepared individual in our business office or in our other areas. We a lot of times we grow our own and we educate. And so I think being able to have resources, support from other systems rather than from a competitive, but a help. How can we help this community? How can we help this local provider? Many, many years ago, the relationships of patients that saw their family practice doctor, they went on to those colleagues that the physician had relationship with. Now, and I don't want to get into antitrust and the Stark and all those kinds of things, but I think that still can be true without having to have a contract that says you got to do this or you can't do that. I think there's an opportunity, there's enough on the table for all of us to work better together and more collaborative. Rather than having to own everything or be in charge of everything, how can we work better together? Because if we don't, we're going to see our rural communities shrink, and not because getting access to those resources is becoming more and more difficult. We don't have a $1 million data center to put a new telehealth system on top of, nor can we afford it for the number of people we see. So we've got to find something that's already on the shelf or with another entity that's willing to allow us to sit alongside them to use that. And we're doing that. I'm not saying it's not being done, but I think it's important that not just for our entity, but all rural communities and providers, we need to be thinking about how do we work together. Otherwise, we're going to end up with 9 large health systems across the country that are going to be dictating everything because they can provide those services at a cost or have that power for coverage to make it happen where smaller facilities like ours aren't going to be able to. So that's one thing. I think telehealth is a blessing, but it could be a curse.
Mm-hmm.
I also worry about insurance companies being able to provide that in such a way that they use it to pull patients away, kind of like leaving us with what's left in the emergency room at 2 o'clock in the morning because all the other services have gone away because of that. So
Yeah. Yep.
how can we work together with insurance companies as well? The other thing, and it's no secret, and it's been talked about over and over and over, the cost shifting that's gone on for years and continues. And the reason for the cost shifting is because some government payers are paying less. And it has to get made up somewhere because at the end of the day, we still have to replace equipment, provide increases for employees to be competitive for wages and pay for health insurance and all those things. So Medicaid is probably the biggest one, even though it may be 5 or 7% of our total patient base. The last number I'm aware of, and this is more specific regionally, Medicaid was paying on average 22% under the cost of the service. Not 22% of the price or the charge, but the cost of the service. Now that's going to vary, and so that's just, it's a real loose number, so don't put any weight on that. But the fact I can stand on is the payment in many times is less than the cost of providing that service. That's an inequality that because of participating in the Medicare program and being in a rural area, we see older people and poorer people, whether it's Albert Lee or Blue Earth or Fairmont or Worthington or anywhere across the state, Big Fork, Minnesota. That's true. We see that. I think to some degree the state has to step up with that. And that's a tough thing to say. I know they've got their challenges and they've got budget issues as well. But if you want rural facilities to be around, I think that's one way to help us.
Awesome. Yeah. Thanks for that. I'm going to throw a question at Brad, and then I do want to circle back around one more time. There was a question, and I'll ask Santo and Rick to kind of think about this question. I'll just read it here real quick. As we've been forced into innovation with the recent pandemic, we are seeing community-based organizations partnering with healthcare providers and developing a model similar to Hospital Without Walls. Do the panelists believe this will continue post-pandemic? If so, will this be something that rural Minnesota will embrace as we see not only hospitals and clinics closed, but also nursing homes closed? So I'll let you guys kind of mull that one over. Brad, I have a quick question for you. Take a couple minutes to talk about this one. So Rick and Santo kind of talked a little bit about, starting conversations with your local providers as early as possible and try and develop that relationship with them. Now, you had mentioned that the state tried to step in and force the hand a little bit, telling Mayo, hey, go to the table with these guys and negotiate or at least talk to them. What do you feel like would have been more helpful in your situation to make those talks more, a little bit more productive? Was there a relationship with the Mayo beforehand, or did it kind of try to start then? I guess give us a little insight there, and then kind of, what ways might state policy, if any, kind of help in those situations?
We had a political subcommittee who was in charge of this aspect of it, and we were very much engaged with not only our local government, from the mayor on down, but also our Peggy Bennett, our local representative. I mean, we had conversations with the governor, the lieutenant governor, the attorney general. And they were really good listeners, and they did encourage Mayo to have conversations with us. They did not encourage Mayo to negotiate with us. I don't think there was any pressure put on them to do that, but they at least wanted Mayo to negotiate or to talk to us. And it just ended up being, okay, here's how we're going to implement this. And that became apparent really quickly. In terms of what could be done, looking forward as to what we're doing right now, we're building a full service clinic that goes as far as outpatient surgery. Someday we would, we were birthing 300 to 350 babies a year in Albert Lake. That's a real hot item for us. Our population wants birthing services back in. We're going to have intensive care to be able to do that. We're going to have hospital beds to be able to do that. Yet, how do we get them? Mayo controls all of them in Freeborn and Malheur County. So how are we going to get those back? I think there needs to be, it wasn't that long ago. Look at what St. Peter did not that long ago. It was a while ago, but St. Peter was able to put up a critical care hospital, even though they were 12 miles away from Mankato's hospital. That can't be done anymore. You used to be able to get exceptions there based upon certain circumstances and patient counts and things like that. Albert Lake cannot get that today. Is there, in order to be viable for rural communities, there's got to be higher Medicare and Medicaid reimbursements. 60% of our patients are Medicare, and that's common across southern Minnesota. I'm sure northern Minnesota too. There should be some sort of requirement about when these things are happening, some sort of medical impact studies have to be done, and some sort of economic impact studies have to be done. There should be some sort of law that requires, before this can happen to a community, that those kind of things have to be done. Because it's absolutely devastating to a community. The only thing that's close to it is losing your school, which is another issue altogether.
Yeah. Thanks, Brad. Appreciate that. Well, I'm going to circle back to Santo. I know you got disconnected there for a second. I don't know if you heard the question that I asked you and Rick to kind of ponder a little bit. Were you able to hear that?
No, could you repeat it for me? I'm living proof that there's not as much rural broadband as there ought to be.
Yeah, it makes you wonder about telehealth a little bit. Huh? Say, yeah, this was a question I thought it was really interesting. So as we have been forced into innovation with the recent pandemic, we are seeing community-based organizations partnering with healthcare providers and developing a model similar to Hospital Without Walls. Do the panelists believe this will continue post-pandemic? And if so, will this be something that rural Minnesota will embrace as we see not only hospitals and clinics closed, but also nursing homes as well?
Oh, I think absolutely. This is something that, to be perfectly honest with you, this is probably maybe not where the questioner was going, but I think it's a question of you will either do this strategically on your own in the very near future, or you will negotiate the terms of your own surrender in the long term. The imperative of cutting costs and finding ways to coordinate care outside of the walls of the hospital have completely changed the model of sustainability. We run one of the largest accountable care organizations that we have a number of different non-centric care providers that are part of it to manage a Medicare population throughout central Minnesota. And that gets into that kind of that total cost of care or that risk-based model that you talked about earlier. We're also involved in doing jail medicine in conjunction with local public health, local human services, local detox. So we have some really amazing data to show, and this has been. We got an award last year from the Minnesota Counties Association and from a number of different national groups. Basically, we took folks that were living in one of three places. They were living in the jail, detox, or the ER. And they were basically living between the silos because we weren't communicating with each other and we were not serving those people well. That's on us. That's on the community to an extent. And so we formed a collaborative called the Central Minnesota Mental Health Steering Committee. The judges sit on it, the public health sits on it, the defense bar, the prosecution bar. It's really, I want to say over 40, basically interested stakeholder parties that coordinate to serve these individuals better. It's done entirely through their own consent. And for some of these folks, the costs are tens of thousands of dollars less per individual. And it's not just about the cost. They're not spending their nights in jail. They're not spending their nights in detox. One of the individuals that I would just add that's so important for I think folks to hear about, when we ran the data and we were doing a presentation for the Minnesota legislature, they pulled the data from, again, another non-central care entity, the Central Minnesota Mental Health Center out of St. Cloud. And Dr. Rickley asked for the data to be pulled about how many days this individual who had spent 123 days in 2017 in his detox center, how many days he spent in 2018. And his billing office told him, we've billed 0 days. We believe he's deceased. The reality was he was happily living in St. Cloud. We know that he's not deceased. He's still a member of the program. And so dramatic changes, and there is real, I don't want anybody to think, well, you just can't cut costs. There's no fat in the system. The fat in the system does not exist where oftentimes policy makers think it lives. And they really focus on that price. And that's where you're hearing from this panel, a uniform position that Medicare and Medicaid reimbursements as applied to rural healthcare access is an unsustainable model. We do need more. However, are there ways we can coordinate care and do earlier interventions in a way that actually save the taxpayer a significant amount of money so that that money isn't being lost to jails and to detox and to you name it? Absolutely. Absolutely. So we can do better. We can all do better. We can all improve and we can save money. But I think that we go to the normal the usual suspects. How much you charging for this and how much you charging for that, when we're not looking at the silos of how many days did this person spend in jail? What could we have done to get ahead of their alcoholism with depression treatment and rural mental health access and the like? So there's money out there to be saved. We just have to take a broader view of it.
Thanks, Santo. Rick, what would be your response to this?
Well, I think we're all prepped together on the same chapter. I think we're all singing the same tune. Maybe just to go a little bit askew from what Santo was saying, maybe not askew, but alongside. We're talking right now in our community, and partly because of the challenges law enforcement and healthcare are struggling with the adult mental health needs in our communities. We're seeing them in our ER, and unfortunately, we're a physical, medical health, not mental health hospital, and so those resources aren't available. So you look for placement, and of course there aren't any open beds, and so they're in the exam room for 6 hours a day, 2 days, 3 days. Same thing with law enforcement. You've got folks in jail. They're there not because they committed a crime, but there's no place for them. They have mental health needs. So, we're talking with Faribault County law enforcement, ourselves, and some public health and human services about what we can do about that. Because it costs someone, and taxpayers ultimately, or patients, for that person to be sitting in jail or to be in our ER and having one-on-one care, to pay for that RN to be available there. And so I think Santos and everyone that's talked about this is right. How can we use those funds differently to, one, improve the care to those people, get care to them quicker, and resolve the issues quicker, and actually be able to still pay for that cost of that care above the cost, or at least that cost anyway, and we all lift the tide. So yeah, I think we have to look at how things are provided differently. And I think in rural communities, if you give people the platform and hopefully the state to help us convene, get us together around the table to figure some of this out. So it's not so much about yours or mine or those kinds of things, but how do we do this together so there isn't that financial disincentive to do that. I think we can make some great strides, but we're not there yet.
Yeah. All right. Well, I think that runs us to the end of our webinar. For all the folks that have been asking questions through the chat and the Q&A, we're documenting all your questions. We're actually going to send these out to our panelists and follow up with them and get some answers for you guys, and maybe write a blog post or something like that. We'll send that out in the next few weeks. And so don't feel like we're leaving you hanging. We didn't want you to feel that way. To our panelists, Terry, Brad, Santo, Rick, guys, thanks a lot. Really, really appreciate your time. Thanks for everything that you guys are doing. I know this is crazy times. I so appreciate you being able to take some time to talk to all of us and talk about something just so important right now. With that, I guess, thanks to all of our participants. Thanks for everybody ask questions, and take care.